Kia ora koutou. Welcome to the second of the Evidence to Practice sessions hosted by the Puna Aonui Business Unit. Nice to see you all here today. I'm going to start us off this morning to open with karakia. Tūtawa mai I runga, tūtawa mai I raro, tūtawa mai I roto, tūtawa mai I waho, kia tau ai te mauri tū, te mauri ora, ki te katoa, haumie huie taikie. Thanks everybody for joining us. We know that some people were here last month and it's great that you've come back again and fantastic to have some new people joining us. Ko Cheryl Han toka wingua. I'm He Pakeaho. I'm the Chief Advisor in the Puna Aonui Business Unit. Happy to be the facilitator for you today. Before we get started and welcome our fantastic guests, just wanted to go through a few messages just to remind you that in this version of Teams that we're using today, you can only see the presenters, so you can't turn on your camera or the chat function, but you can use the Q&A function at the top to ask questions, and we really invite you to do that. There'll be opportunity for your questions to be answered in the last part of this session today. You can't screenshot or independently stream or record the event, but we are recording it and it will be on our YouTube channel pretty soon, and we're going to post the link to that in the chat, so you'll see that. We're pleased to welcome Dr. Claire Gear and the team who've been working on the Atawhai project, responding to family violence in primary care settings. Claire's going to be presenting for about 15 minutes. And then we'll be bringing in some of the research team, and you'll have a chance to ask those people questions. Those questions will be facilitated by Dr. Adrienne Everest, who is a principal advisor in the Puna Aonui Business Unit. We're going to get through as many of those questions as we can. Just a reminder that we want this to be a safe and inclusive space for everybody. These sessions are going to cover topics of sexual violence and family violence that can be difficult or distressing. So please do what you need to do to keep yourself safe and to get the support if you need it. We're going to be posting the links to help portals where you can phone or do online chat or text or find out more information about help that's available in your area. And lastly, please feel free to send us any questions or feedback or ideas. We're going to put our email into the chat as well and our website. And you'll be able to find the recording for this session on our YouTube site pretty soon. The link will be in the chat as well. So now I'm going to welcome Dr. Claire Gear. Thanks for joining us, Claire, and your team. Claire's the Senior Research Fellow at the Centre for Interdisciplinary Trauma Research at AUT. And I'll pass over to you now, Claire, so you can introduce yourself more if you'd like, and we're really looking forward to hearing from you. Thank you.
Kia ora, Cheryl. Tēnā koe mō te karakia. Kia ora tātou katoa. Ko wai ko Mawau te maunga, ko Tauranga te moana, ko Ngāti Rangi rawa ko Ngāti Rangi nui nā iwi, o Opu Tamariki me tōko o tāne, ko Claire Gear toka wingua. So kia ora, I'm Claire, Senior Research Fellow in the Centre for Interdisciplinary Trauma Research at AUT, as Cheryl said. And thanks for coming along and taking an interest in the findings of the Atawhai study. I'll present a brief overview of the study and then some key findings for policy and practice. So if I could have the first slide, please. Next slide. Thank you. So Atawhai is built on more than a decade of research seeking to improve primary care responsiveness to family violence. So this Atawhai study, we began with the understanding that family violence is a key determinant of ill health, which is currently inadequately addressed within health policy and practice. It's a complex problem. As we know, there's many different and constantly changing factors contributing to family violence, and this makes it impossible to predict what will happen. So any response developed needs to account for that complexity and uncertainty. It's also a profound gap. There's limited healthcare policy, funding and resources to support the primary care sector in responding. And that makes it an urgent issue as primary care professionals need support to know what to do and how to help. And primary care is one window of opportunity to be able to create a safe space to listen and kōrero with whānau.
Yeah, we're just fixing the slides so
Okay,
you get a proper view. For me, just a minute. Thank you.
Thank you. So given the limited health system support for primary care, we aimed to work with primary care professionals to understand what would make it easier for them to be responding to family violence in practice. So Atawhai was funded by the Health Research Council in 2020 to answer the following questions. What does an effective and sustainable response to family violence look like for primary care? And what influences change in primary care family violence responsiveness? Next slide. And key to the study was how we approached the problem. So our previous research called attention for the need to approach the problem in a different way, and that those working on the front line were best placed to identify what will make it easier for them to respond to family violence. So complexity theory focuses on the patterns of interaction between system parts which lead to system outcomes. And our participatory methods connected us to local knowledge and experience. So rather than viewing the problem from the outside looking in, we were working with participants and developing an understanding of the problem together, uniting different bodies of knowledge and building mutual understanding of problems and solutions. Atawhai is also strongly grounded, go back one more, thank you. It's also strongly grounded in Te Ao Māori principles. So it's the Te Ao Māori lens that really took this study beyond the Western ideas of co-design. The principles of manaakitanga, whakawhanaungatanga, and whakawhitipiti kōrero all help to create genuine relationships that were responsive to real-time collaborative learning amongst our participants. Next slide. So this process occurred through 10 one-day wānanga, where we supported participants to draw on their contextual knowledge and practice to critically reflect on what information was required and how it might be integrated into practice. And I just want to mihi to the Atawhai whānau here and acknowledge that I am presenting this mahi on behalf of them. As you can see from this photo, it's really the relationships that were built through this work that has been the most meaningful achievement of this research. Next slide. So one of the key findings of Atawhai is our relational response to family violence. And this is encapsulated with what we call the Atawhai kōrero. So we talk about kōrero, about family violence being many shared moments in time within a relationship underpinned by tika, pono and aroha. It's about realizing that we don't have to fix the problem, but be someone that whānau can trust to walk alongside and support opportunities for change. And care is taken so any kōrero is responsive to and safe for whānau. Next slide. Our participants also identified 4 key pathways to responsiveness for the healthcare system. And of course, first is recognising family violence as a key determinant of ill health. And over the course of the research, our team has had many conversations with decision makers in healthcare leadership to help this happen. We also advocate for resource, clinical and cultural supervision and peer support. We heard during the study, we heard that there was a lack of supervision for clinical providers. And that's really critical for them to have the time to be able to debrief around this issue, to share the uncertainty and to discuss care options. We also heard that medical services struggle to know who to refer to, while community services are relying on those referrals to be able to provide help. So Atawhai is about growing meaningful connections between these settings and generating trust between people so we can have improved outcomes for whānau. And finally, tuituiara is about, rather than establishing another information database, it's Atawhai is about connecting people to people, allowing for case-specific and up-to-date information sharing through the network. Next slide. So our first research question asked, what does an effective and sustainable response to family violence look like for primary care? And we found that it is about having a network of trusted relationships between clinicians and kaimahi who share skill sets and information to support safe relational responses to whānau and families responsive to complex needs over time. So in response to that finding, our participants established the Atawhai Network. And this is a distinctively primary care-led network that is about connecting people to people, information and tools, about translating knowledge across different settings, and about driving change in policy and practice. Next slide, please. Our second research question asked, what influences change in primary care family violence responsiveness? And Atawhai has really advanced current thinking in this space by calling attention to two system elements that aren't often considered. And the first is around critical reflection. So we found what is often lacking is critical reflection on the systems and structures that underpin our individual and our collective stances on what is the problem. It's these structural influences that shape how we think about family violence, and therefore how we design our responses to family violence, and therefore how responsive we can be in practice when working with people who are impacted by family violence. So it really is critically reflecting on why we do what we do, and do we agree with why we do what we do. The second element is around quality relationships. So often building quality relationships can be taken for granted or be undervalued. But Atawhai has really demonstrated the critical importance of trusted relationships for addressing family violence. We found that interventions that focus on increasing the quality of relationships between diverse providers are more likely to see the emergence of sustainability over time. Next slide. And these two elements are interdependent. So it is the relationships that enable the learning, and it's the learning that creates the change. So during Atawhai, we saw transformative change occur as participants grew trusted, quality, interpersonal and interorganizational relationships that enabled them to learn from one another and therefore critically reflect on the way that they were thinking about family violence. And what is learned is dependent on the nature and the quality of the relationships formed. So it does matter who the relationships are built between and for what purpose. And this is in contrast to the everyday focus of transactional learning, but transactional teaching and learning, rather than a focus on learning through relationships. Next slide. So some practice lessons from Atawhai. The first, of course, is recognizing family violence as a key determinant of ill health. But rather than writing this in policy or practice, it's more critically reflecting on what this means to your community or your organization. How does recognizing it as a key determinant of ill health align with your organizational philosophy? It will look different in different settings and spaces, and Atawhai offers principles that can be interpreted across different settings. Build your peer support and supervision. As we've found, quality, trusted relationships that support practice leads to sustainability. And encourage reflexive and relational engagement. Think about how the way I think about family violence influences the way I respond to someone. And be comfortable with being uncertain. The complexity of the problem means that we can't predict or control what might happen. We need to reduce the pressure to fix the problem, rather offer opportunities for change that are responsive to people's needs. and shift the focus from disclosure. Interventions can look different, and sometimes a conversation can be an intervention in itself. And assess and build workplace readiness. So what support do your providers have to address family violence? Do they have the leadership and community engagement needed? Are they integrating with other services like housing and employment? And do they have the individual self-efficacy to be able to deliver a response? Next slide, please. And some policy lessons. It really is about recognizing that we're working within the problem and we can't stand outside of it. The complexity of the problem means that we are contributing to parts of the problem, as parts of the system rather, that are influencing family violence. So as such, we need to work with the implications of a complex system in mind. And this can be, recognizing that you can't know the entire system, you can only know a part of it. That there will always be uncertainties and unknowns due to the constantly shifting elements. And that relationships and trust are essential for connecting the system together. We need to create conditions that help share learning relationally. For example, our Atawhai whānau brings people together, brings diverse providers together to share lessons and learned and to create support. And spot the emergence of new and helpful patterns and encourage them to grow. This is our Atawhai Network, growing our relationships through the network for support. But it could also look like engaging researchers to conduct developmental evaluations along the way. And be aware of how institutional arrangements and ways of thinking can create barriers to collaboration. Healthcare is just one part of a much larger system that's seeking to address family violence, but we have to play the part. Next slide, please. So the Atawhai findings are freely available in the archives of public health, and we also have a summary infographic available. Next slide. And I just wanted to leave you with this great picture of our wānanga that we co-hosted with Ngāti Awa in Whakatane late last year, and the number of people that are on the waka with us. And our whakatauki, e hara takatoa, I tō takatahi, engari he tō takatini. So kia ora, and I'd like to invite the research team members who are here to join me and introduce themselves. Kia ora, Gabrielle.
Kia ora. Kia ora koutou. Ko Puwhiki taku manga, ko Karikari te moana, ko Mamaru taku waka, ko Ngāti Kahu te iwi, ko Gabrielle taku ingoa. So my name's Gabrielle Moss. I am the clinical director, one of the clinical directors and a GP at Turiki Health Services, actually based in East and South Auckland. And I'm also a family violence intervention program trainer within primary care. So my role is to upskill GPs and practice nurses and primary care health professionals to be able to have conversations about family violence in their everyday mahi. So that's my background, and I have been privileged to hold the position of co-chairperson in one of the Atawhai projects.
Kia ora, Gabrielle. Kia ora, Hazel. Did we lose it? Oh, no. There you
go. Kia ora whānau, ko Hazel hapi ahau, no tauranga moana ahau, ingari te taha tōku pāpā, no te tai tukarau. I'm Hazel, I've been on the project team. My day life, I work at Women's Refuge in Tauranga Moana, have been on the kaupapa since 2004 within the korowai of ngā whare whakaruruhau o Aotearoa, ki tauranga moana, but also regionally and nationally. And I'm very passionate about supporting kaimahi to be the best that we can be. So what we do with our whānau, our wahine, our tamariki, our tāne, our whānau, our hapori and community is meaningful, and their kaimahi feel supported to be the best kaitiaki that they can be with our whānau. Kia ora.
Kia ora. I'll pass it to you, Adrienne.
Kia ora koutou, ko Adrienne Toko Ingoa. I'm from Te Puna Aonui, as Cheryl said earlier, and it's my pleasure to facilitate a Q&A, and just reminding people online, pop all of your questions in the chat and we'll try and get to as many as we can. Thank you to the team for that wonderful and interesting presentation, a really exciting piece of learning there, and I was particularly excited to hear about that sort of movement from the transactional learning to the relational learning through quality relationships. That really resonated with me. And also that place of reflection where often we don't have enough time in our busy lives and our busy work to actually take that time to reflect and connect and make those quality relationships across the system. So thank you so much for that. We'll just kick off a question now, and one of the questions that has come through is, if people want to connect with the network, how can they do that?
So the easiest way is to visit our website, www.atawhaitia.co.nz, and sign up on the website. Post-research funding has been limited, so we are hoping to continue to offer network opportunities in the future. So the best way is to keep an eye on the news and events on our website.
Fantastic. Thank you, Dr. Gear. And you'll see in the chat that there's a link to the website there for everyone that can get more information and learn more about this wonderful initiative. The second question is, do you have any advice to other regions who are wanting to take a similar approach?
Yeah, so I think the first step that you want to do is build your peer support. Find those like-minded individuals that are interested in improving this area of practice, and yeah, build your own network of support and hopefully grow it from there. And of course, draw on the Atawhai principles that we have available and resources that can help you in that space.
Fantastic. Thank you. What would you like to share, if any, advice about how to build and create safe spaces to do the work?
I might ask Gabrielle or Hazel to speak to that one.
Gabrielle?
So obviously from my perspective, that's a primary care kind of perspective. Safe spaces, I mean, you know, just around the kind of the very practical approach to that would be, you know, ensuring that our health facilities really promote themselves as being safe spaces, and you can do that in a multitude of ways, right from, you know, reception to the doctor's consulting rooms. So at Turuki, we have posters everywhere saying, you know, we do have conversations about family violence, intimate partner violence here. This is a safe space for you. So we kind of introduced that concept right at the outset. We've all been through the training, right down to receptionists, health coaches, health improvement practitioners, which are kind of a new concept within general practice. So we're all familiar to an extent around the dynamics of intimate partner violence and things to be conscious of, I guess, and also kind of looking at ourselves as to how we feel personally about those issues, because as we know, within the health sector, we are more likely to have had a personal experience around those issues. So, you know, doing that mahi before you kind of have an approach to your clients, to your patients. So posters, introducing the concept right off the bat. So, for example, with our new patients, I encourage staff to be asking all women, is this an issue for you? Are you currently in a relationship? Can you tell me about your relationship? Are you feeling safe currently? So normalising conversations within primary care so that it is considered to be a health issue, right? So as Claire was saying before, the most important thing I think about this project is that we're saying, hey, family violence is actually a health issue, and as primary care health professionals, we are acknowledging that and working from that perspective. So within primary care, that's how we keep those safe spaces.
Thank you, Dr. Moss. It's wonderful. Another question here is, how does ensuring the wellbeing of professionals through Atawhai's support structures translate into better treatment and care for whānau?
Yeah, so I think our participants, they were given an opportunity to do this work in the critical reflection and have the time to consider that. And that translated into practice where they felt more confident and capable of asking the questions and having that kōrero, and that therefore translates to better care for whānau. We're yet to do work that looks at how that happens, but that's the anecdotal evidence that we have of building confidence and capability, feeling like they can do this work and know how to help. So yeah.
Great, thank you. How does the space for the critical reflection, which I heard was a key piece of your learnings, provided to the health professionals in Atawhai, impact on the quality and recovery options available to whānau? And again, it might be that you haven't quite dived into that, but yeah, people are just interested to ask the question anyway.
So how does the critical reflection impact on the quality of...
Yes, so that reflection of practice, how might that impact on the quality of treatment and recovery options for whānau, having that space and that practice space to reflect?
I think it's the learning that comes from the critical reflection, understanding that people have different circumstances, different constraints, and being open to seeing the world from different perspectives. When you can do that, I think you can engage more genuinely and create a more genuine relationship with the person that you're working with. I don't know if the others have something to say about that.
I probably just want to make a comment back to the earlier partai around, so like, what does safety look like? For me, it really is about who you are as a person. Like you know, it's important to have training, supervision, tools, resources, and koha. But when we're engaging with whānau, whether that's within a primary health setting or community-based setting, it's all about you. So if you are tau, if you're a safe person, if you're an informed person, if you're aware, then you know you're going to get it right from the start. And then all those other resources and rauimi that sit in those spaces, whether they're posters, resources, forms of information, you know, just really support the safety plan that you're putting in place. But kaimahi practitioners are the key to someone's safety and how you engage with whānau. Kia ora.
Kia ora. And maybe I'll draw people's attention to the website, which has some of your wonderful practice gems on there. And just thinking about that, Hazel, and one of them was about know first who you are and where you come from, and doing that, I guess, that piece of work on yourself as well as a practitioner, and reflect on that, your personal journey, to make sure, you know, you have done all the work you need to before engaging with families and whānau. Great. Another one that's just come through is any advice towards applying your learnings into education?
Gabrielle, would you like to talk about that?
Yeah, so interesting, because I've been working in this space for kind of 10 years, and so kind of preceded my kind of involvement with Atawhai, and it really has made me review how I approach actually formally training, teaching GPs. And you know, I think what Claire and Hazel have alluded to there is the key factor, I think, in having these types of conversations, which are really, really hard, challenging conversations for GPs and practice nurses, because this is a health determinant that we can't resolve. We can't give a prescription. We can't give a definitive answer. It is about walking with the patient and having a therapeutic relationship with that patient that ensures that you've got their back and that they trust you. And you don't have to resolve everything today, but you're going to talk about them talk about this issue at the next consultation if they're comfortable too. So that's been one of my biggest learnings, is that this is a long journey and there's going to be ups and downs, and it's not your job as a health professional to fix it. It's your job to listen and to validate and to support and to refer. So I think those are quite difficult concepts to impart on people that are learning, and to people that are quite fixed in the way they have perhaps practiced medicine. Quite challenging, but really, really beneficial, and has knock-on effects for all aspects of how we practice as health professionals, to be honest. The kind of stuff that I've learned in this sector has made me a better doctor for many other aspects of my work.
Thank you. I'm just reflecting back as well to your presentation, and thinking about what you had outlined around institutional arrangements, creating barriers. And I wondered if you wanted to talk a little bit more about that.
Yeah, I guess what we've found in our research is when we talk about integration, it's quite a common thing to say we need integrated family violence services, but there's actually little evidence to show that integration is leading to improved outcomes for whānau families. So in terms of institutional arrangements and ways of thinking, it's like, so when you say let's integrate, what does that actually mean? We're using kind of perfunctory mechanisms right now, such as referrals between healthcare and social services. But what we're trying to get at is that when you create the relationships and you understand someone else's perspective from that part of the system, that's where you get more genuine change, rather than relying on these system mechanisms that we keep using. So it is about being aware of the really entrenched ways that institutions work that do create barriers to working with one another. And for us, in the research for Atawhai, bringing together the clinical providers with some community service providers was really, a first time for many of the participants. So it's just one big barrier that we were able to break down in this opportunity of the research project.
Thank you. Lots of reflections to think about there. We've got one just coming in. Given that GPs generally have only about a 15-minute window when they're seeing patients, how can they identify that family violence or sexual violence could be an issue?
Is that one for you, Gabrielle?
It's a me question. Yeah, so again, I come back, yes, we're all pressured for time, and we've got lots of things that we need to cover in a 15-minute consultation. Can I just say that at Taruki, our management team recognise that we need longer, so we have 20-minute appointments for that very reason, that we're dealing with patients that have very complex issues. But my message there was, there is always time for these conversations. And you don't have to complete the conversation in the consultation. You may just be planting the seed. And so we have, in our teachings, we have set routine inquiry questions that we encourage people to use. And we do it as part of just a general kind of screening. So we're asking about cervical screening, mammograms, and we're going to be asking you about family violence as well. And sometimes that only takes a couple of minutes, right? And you've planted the seed, you've got a a no response, that's fine. But we're going to bring it up again in the future. So those conversations can be started and parked is my message there. And look, then you may well have a conversation where you do get a positive disclosure. And so that's around that, motivational wheel of change. Where is that woman at in terms of her journey? Would she like to talk about it today? Would she like some help? And it's like everything. It's like mental health. It's like suicidality. If there's risk factors there, you're going to park everything else and you're going to deal with that issue. So it's no different to any other health issue in my perspective. And if you start addressing the family violence, well, hey, some of the other health outcomes might improve as well. So it's beneficial for you to include it in your mahi.
Kia ora. And going back and reminding people, you're not fixing the problem, and that, that short window, you're just opening up the kōrero and listening and doing what you can. And that's wonderful. Thank you. Another question here. Kia ora. Love the idea about clinical and cultural supervision for kaimahi. What are some ideas around cultural supervision needs?
This is something that we want to explore further, as having identified it as a need in this part of the research. So we're not too sure what cultural supervision or general supervision looks like for primary care at this stage. What we did experience in the research was a lot of learning around the impact of colonisation on health and wellbeing for Māori. And some of those conversations were challenging, but there was a lot of learning that went on, and it was beneficial to the project overall. So I think, I don't know, Hazel, do you have any comments around supervision?
Well, just in terms of members of the rōpū, from a cultural supervision context, as kaimahi, we're dealing with whakapapa, we're dealing with bloodlines, we're dealing with genealogy. We're also dealing with what you can see and what you can't see, what you can hear and what you can't hear. And so as a result of that, there are times where practitioners kaimahi are looking for mātauranga that is embedded and grounded within Indigenous worldviews and lived experiences, or Māori worldviews and lived experiences, to basically give them guidance, to help shape their direction, to provide support, to provide a place of reflection, awhi tautoko manaaki, so they can work with whakapapa and whānau in a way that is culturally safe for them as a kaimahi and practitioner, and for the whānau or the hapu or the iwi or the community member that they might be engaging with within that context and time across a broad range of primary health settings. Kia ora.
Kia ora. What family violence training did you undertake?
Who's that directed towards?
It's just a question here, so maybe we could take it to what is the existing training available around this?
Gabrielle,
for family violence.
Yeah. So currently there's a formal training which is overseen by MedSAC, which I'm sure most people will be familiar with, medical specialists in sexual abuse care. So MedSAC hold a contract to deliver training to primary care, which is a similar contract to what exists in the DHBs. Currently, there are 3 or 4 of us trainers around the motu, and that, as Claire well knows, has been a difficult process to implement because it relies on basically practices putting up their hand and asking for the training. And there are so many other competing priorities and CMEs, et cetera, that it doesn't have great uptake. So what we have developed is some e-learning modules, and we're just actually finalising those e-learning modules now. Obviously, we recognise that people are learning in different modalities now, and that e-learning is much more digestible. So that is the current training that exists in primary care, which is fully funded and free. but we also will tag onto that a kind of a face-to-face training, so we get to do case discussions, practicing, doing role plays, etc., etc. So it's a three e-learning modules, quite a comprehensive formalised training.
Thank you. There's just a few comments saying that they love that relational aspect, the importance of that, and shifting the focus away from disclosures and I guess the transactional that we talked about to the real conversations. So just a bit of feedback of encouragement. And also a question here about we would like to link better with primary care from the tertiary to the primary. We struggle to find shared tools and ways of communicating from tertiary to primary. Any comments on that?
That's from the hospital level to primary care sector?
Yeah, so Family Violence Program Coordinator, Te Whatu Order question.
I guess it is, again, about creating that network of support for yourself.
Mm-hmm.
So finding out who the primary care providers are that are working in this space. It's something that the Atawhai Network could work on in the future, is being able to connect people regionally or let people know who's working in this space regionally. Yeah, any thoughts, team?
Yeah, I guess, I mean, I can only speak from a Tamaki Makaurau perspective, but I think there are kind of different regionalised approaches to it, aren't there? I know that we have a system where there are perhaps alerts on individual whānau that come out of the hospital system, you know, on their discharge summaries and things like that. So, I mean, we get that kind of notification, but there doesn't seem to be a good, robust national approach to communicating risk from secondary care to primary care, unless perhaps kids have been through like a gateway type process in some of the child protection services. So again, it's that very siloed phenomenon that exists in health, where you're trying to, you know, control that unwieldy beast of primary care, which is multiple different businesses and clinics, which is very difficult to rein in that kind of effective communication system. I agree, it's really, really hard, and to kind of notify people where there needs to be communication between the two sectors.
Mm. Mm. There's another one here around people being interested in your comments on integration, and particularly looking at the integrated safety response in Canterbury, with health being a key contributor to that. Yeah, and just wanting to know sort of like some of your comments around integration within some of those wider, and I guess for us in the Te Rere place and space, what are the implications or learnings we could take from what you've learned in that primary care and responses to family violence to the integrated responses and wider responses involving more than just the primary care providers? Any comments for that? Or?
Yeah, oh, sorry, Hazel, were you gonna?
You go, Claire.
Okay. We have published a paper on a scoping review we did on international and national integrated responses to family violence. And just some of the key findings was that there's a high variation in what integration looks like and different understandings of what integration looks like. We identified three kind of broad pathways that integration is currently taking, and one's that systems-centered perspective where the focus is on making the system parts work better together. Then there's a person-centered pathway, which is where we think healthcare might fit, and it's about the individual and responding to that individual in time. And then the third one was Indigenous perspectives, so that's that holistic view of family violence itself and integration, which differs quite a lot to kind of the system-centered and person-centered views. So I don't know if anyone has the link to that paper, but it could be put in the chat. Hazel.
Ka pai. Look, I just wanted to go back to the other pātai. So I think that in terms of like how do you strengthen communication and relationships in and out between tertiary and the primary sector is this is where NGOs like Refuges or NGOs like other community helping organisations have a key role of bridging in and bridging out with information and being a connector between the tertiary and the primary care settings, and then that getting triangulated into a network, a looped conversation, because it's generally the NGOs that are outside your sectors that have access to a range of information at a grassroots level, community, to me level, and that can be shared into those spaces and to build relationships as well between the tertiary and the primary sectors.
Thanks, Hazel. And no problems if you guys haven't got the paper ready. We can maybe send it out with our later on with our recording of the session for people that are interested in reading that. Another question here. Thank you for all these wonderful questions. There's obviously a lot of engagement and interest in your kōrero, which is amazing. Here it's one of the lessons is about shifting the assumption that taking action means having to fix the problem. Can you say more about that assumption and forms a barrier to helping, and also what primary care helpers can actually do for people that will be helpful?
Did you want to take that one, Gabrielle? Or?
Yeah. So I guess that's saying, so what are the actions we do take rather than fixing the problem? So I think let's not forget that we're dealing with adults here, right? So we're not dealing with children who we have to make a formal notification for. We're dealing with adults. And so at the end of the day, it is up to the person living in the violent relationship as to what kind of help they might need, and whether they want to tell us what's happening, and et cetera, et cetera. So I guess that's my approach, is to have those types of conversations, identify that it's an issue, identify that it might be impacting on her health, and then offer her support and referral. And actually, it is up to that person to instigate that and accept the support, or take further action in terms of her own well-being. So that it's not me fixing, that it is me being the conduit for her to access support.
I think when you, sorry, you go.
I just want to, just was thinking about, like, for us as, just from a humanitarian perspective, like, it's important for us to take a deep breath, because it's about acknowledging that what you are hearing, seeing and feeling and witnessing and experiencing, it's heavy. Yeah, family violence is heavy, and sometimes in our wanting to get action and do things, we need to remind ourselves to just stop and then move forward, as Gabrielle was saying, with resources and pathways and plans to support whānau who may need support. But it's really important to just acknowledge the taumahatanga, the heaviness that comes from dealing with family violence, and then moving forward. Kia ora.
Kia ora. And I think that not to underestimate what those learnings were about just listening to. That can be huge for someone, as we know, in the space that we work in at Puna Aonui. To be just listened to is huge in itself. So, in a caring way. Yeah, lovely. Thank you. Another question over here. Sorry, I'm reading them from multiple places at the moment. Can someone from outside the health system access the family violence training for me as a family violence agency coordinator to help understand their policies, etc.?
Good question.
Oh, yeah. Probably not the primary care training, because that is specific for health professionals. However, I do know that there are other types of e-learning platforms around family violence. Shine do a really good one, which is more generic. So, I would be looking into other organisations that provide that type of service.
Mm.
And MedSAC would be a really good kind of place to go to find that out, or the Family Violence Clearinghouse would have that information as well.
Thank you, Dr. Moss. I'm realising we're nearing the end of our Q&A session, but I just wanted to give opportunity for any of you. We've had quite a few questions and it's been quite fast in the asking, so I just want to give you opportunity to reflect back on any of those questions or add anything else before we hand back to Cheryl for closing.
I was going to comment on that, shifting the assumption to fix the problem. And just say we had a really great participant quote where she talked about, you know, no one's expecting me to fix this systemic, societal, intergenerational problem in 15 minutes. It was just this pressure that she had put on herself, but realizing that, you know, you can't change such a huge issue in a 15-minute session was quite freeing. So yeah, I just wanted to contribute that.
Probably my only other comment would be is that, you know, so long as we continue to not have a coordinated approach, women and children and men will continue to die as a result of family violence. So unless, you know, Te Aorere Kura actually aligns itself to be implemented across the 10 to 11 departments from the top down and the bottom up, then unfortunately, whānau, we're going to continue to have casualties, which will mean that training, supervision, resources will continue to be an integral part of helping to keep practitioners in our spaces and places confident, skilled, experienced and well to continue to do what we are currently doing. Mauri ora.
Kia ora. Thank you so much for your time. I really appreciated the kōrero, and I know from the engagement through multiple platforms and interest in what you're actually saying and the work that you're doing. And we're very excited, and thank you so much for the opportunity. People again can go to your website, learn more, and I'll pass it back to Cheryl now for a closing. Thank you.
Thank you so much, Kia ora. Thank you so much to the Atawhai research team, to Hazel, Gabrielle, Claire, Adrienne. Thank you for your questions asking. We hope you found this session really useful. We would really appreciate your feedback and your ideas for future sessions. So we've posted our email address. Please use that. Send us your thoughts and suggestions. A reminder that we'll be back here hopefully this time next month. We are looking at sessions on violence within natural disasters, and in November we're looking at some research on men, masculinities and men's change journey around family violence in Aotearoa. So we've also had suggestions on discussions around stalking and around whānau-led responses. So if you've got some other things you'd like to hear about as well, please let us know. We'll just keep on organising them and hopefully you keep on turning up. A lot of people were asking about training. You can get all that information about what family violence and sexual violence training is available from the Family Violence Clearinghouse, and we've posted the link to that. And I found that research on integration by Googling, and it was really great. So we'll find that link and we'll add it to our YouTube site as well when we add this video. We hope that you'll join us again next month. If you're not on the email list, please email us and get on that list. And go well for the rest of the day. I'm just going to close us out and send you on your way with karakia. Thank you so much. Kia tau te rangi mārie ki runga i ngā iwi Aotearoa. Haumie, huie, tai kie. Thank you, everybody.